Hello everybody, I'm Dr. Armen, Professor Armen Astvatsatryan from Yerevan, Armenia. So for you, I'm just Dr. Y. And today's question of the quiz, of tests, it will be Angina Pectoris, 3 questions. So questions with answers. The most common questions or possible questions on the exam. So be careful, this is a test system. I will ask you a question. Actually, I don't know the answer. I will see the answer. And we'll talk about these possibilities. So test and 4 possible answers. Angina pectoris. So let's go on. First question, angina. Yes, be careful, please. So angina pectoris is usually described as chest discomfort rather than as a chest pain. No, okay. But actually it's a pain. Anyway, the symptoms of angina pectoris may be vague, barely troublesome ache, or may rapidly become severe. Intense precardial crushing sensation. Although the location of the discomfort varies, it's most commonly felt at which of the following locations? Okay, so locations. So possibility A, beneath the sternum. B, down the inside of the right arm. C, in the throat, jaws and teeth, in the upper abdomen. So of course correct answer is beneath the sternum. Classic pain. Pain going with exertion or discomfort of chest pain. Discomfort in chest during physical exertion, physical exercise. Second, for typical pain, beneath the sternum, so possibility A, version A. And pain goes when you stopped or you take nitroglycerin. So beneath the sternum, let's see, am I correct? Beneath the sternum, yes, that's right. This is the most common location of the discomfort of angina pectoris. So another possibilities, there are other locations where the discomfort of angina pectoris may be felt, but they are not as common as beneath the sternum. Oh, of course, so you can find angina pectoris in my lectures and you will find the answer. So about angina pectoris, I show the link. So next question is what? Second question, when a patient presents with typical exertional symptoms of angina pectoris, ECG is indicated. So once again, my friends, what is typical pain? Pain during or discomfort patient feels during physical exertion and beneath the sternum. And patient reveals after stopping the exertion or after taking nitroglycerin. So because angina resolves with rest, ECG can rarely be done during an attack. An abnormal resting ECG alone doesn't establish or refute the diagnosis of angina pectoris. Exactly, of course. Abnormal resting ECG alone doesn't establish anything or refute the diagnosis of angina pectoris. In order to confirm the diagnosis, which of the following the most appropriate next step? Great. That's great. For questions, so coronary angiography, electron beam computer tomography scan, intravascular ultrasonography, or stress testing. Of course, answer is the stress testing, because what is stress testing? Stress testing is the same ECG, but during physical exertion. And because that physical exertion provoke ischemia during tachycardia, lack of oxygen, etc., can reveal coronary artery, silent coronary artery disease. Stress testing, of course. Answer D, stress testing. Exercise stress testing with ECG is done if patient has a normal resting ECG and can exercise, and stress testing with myocardial imaging is done when the resting ECG is abnormal because false positive ST segment shifts are common on stress ECG. Yes, it might be. So Choice A, coronary angiography is the standard for diagnosis coronary artery disease, but is not necessary to confirm the diagnosis. Anyway, coronary angiography can show plaques. It can show stable angina, for example, but it cannot predict unstable angina and complications such as myocardial infarction. So, why I said about this, because very often patients sent to coronary angiography and they say, yes, you've got nothing. Several hours after, the patient's got myocardial infarction, because we can't not predict what plaque will be disclosed, disrupt. So another choices, there are imaging studies that are used to evaluate the coronary arteries are not to confirm the diagnosis of angina pectoris. So anyway, stress testing is the gold standard for stable angina. And the last question, the main goals of using pharmacotherapy to treat angina pectoris are to relieve acute symptoms, prevent or reduce ischemia, and prevent future ischemic attacks. Which of the following drugs is usually reserved for patients in whom symptoms persist despite optimal treatment with other anti-anginal drugs? So aspirin, nifedipine, nitroglycerin, ranolazine. I suppose ranolazine. Ranolazine. No, I suppose this is a ranolazine. Let's try. No nitroglycerin. Nifedipine, don't think so. Aspirin is obligatory anyway. So ranolazine is my answer. Ranolazine, yes, the answer is good. Correct answer is ranolazine. This is a sodium channel blocker that can be used to treat chronic angina pectoris that is not responsive to other antianginal drugs. Anyway, you don't. We plus ranolazine. We not describe another blocker, another treatment. For example, beta blocker, in this case, plus ranolazine, of course. This is addict, plus, add, not addict, we add this ranolazine. Choice A, this is an antiplatelet drug, aspirin, drug that inhibits platelet aggregation and can reduce the risk of ischemic events, of course, but in angina, not in chronic heart failure. Choice B, this is a nifedipine. This is a channel blocker that can be used if symptoms persist despite use of nitrate. Okay. And choice C, this is the most effective drug for an acute. What is nitroglycerin? Acute attack if used sublingually, of course. Nitroglycerin is a potent muscle relaxant and vasodilator. Yes, but it's not very good for chronic stable angina. But anyway, so our answer is ranolazine plus standard therapy of angina pectoris. So that's all concerning these questions, my friend. Yes. Thank you for your attention. Thank you for your attention. See you in another lectures, another quizzes. Don't make your subscription. Yes, so subscribe and put the ring on. Goodbye.